So without further ado, it's a tremendous pleasure for me to introduce Professor David Williams. I'm going to speak very briefly because his full biography, which I highly recommend you read because it's fascinating, is in the meeting materials. Professor Williams is the Florence Sprague Norman and Laura Smart Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. He is also Professor of African and African American Studies and Sociology at Harvard University. I'm proud to say as a Yalie that he previously was a faculty member at Yale University, as well as other institutions. Dr. Williams is an internationally recognized social scientist focused on social influences on health. His research has enhanced our understanding of the complex ways in which socioeconomic status, race, stress, racism, health, behavior, and religious involvement can affect health. His impact has been enormous. I will not try to capture all the honors and ways in which he's had a substantial impact on our thinking in this area. He was ranked one of the top 10 most cited social scientists in the world, and also as the most cited Black scholar in social sciences in 2008. And in 2014, Thomson Reuters ranked him as one of the world's most influential scientific minds. We can't think of a better person to be our keynote speaker. We're thrilled that he agreed to share his thoughts with us today. And now I'll pass the podium to Professor Williams.
Important program. Thank you so very much. It's an honor to join you today and to be a part of this important program. I have no conflicts to disclose. I want to begin by helping us to acknowledge that racial inequities in health have existed for a long time. In fact, if we look at life expectancy by race from 1950 to 2020, you can see there was an 8-year gap in life expectancy in 1950, and there's a 6-year gap in life expectancy in 2020. It's important to note between 2010 and 2020, life expectancy in the United States declined. It reflects the impact of the COVID-19 pandemic, where we saw declines in 2019. And you also see, because the declines were disproportionate among disadvantaged populations, African Americans and Latinos, you have a widening of the racial gap in 2020 compared to 2010. So what drives these large racial inequities in health? Socioeconomic status, whether measured by income, education, occupational status, poverty, or wealth, is a central determinant of the distribution of desirable resources in society. And in virtually every country in the world where we have data, it's a predictor of variations in health. And race ethnicity in the US context and elsewhere is strongly related to socioeconomic status. I'll illustrate that with data on income. This is median household income in the United States for 2018. And I'm presenting it in a way where you can't miss the point. I'm standardizing on the household income of white households as $1. For every dollar of household income white households receive, Asian households receive $1.23. Asian households are more likely to be multi-generational, so there are more persons contributing to household income. Whites have the highest per capita or per person amount of income. But if you look at the other historically disadvantaged groups, for every dollar of income white households have, Latino households have 73 cents, and Native American and African American households have 59 cents. What is stunning about the 59 cents figure for Blacks is that it's identical to the Black-white gap in income in 1978. You heard me correct. In 1978, the peak year of the narrowing of the Black-white gap in income as a result of the civil rights policies of the 60s and 70s and the war on poverty, the gap was reduced to 59 cents. And in 2018, it is still 59 cents. Has it been stuck at 59 cents all this time? No. It got worse throughout the decade of the 1980s, and it was in the mid-1990s it got back up to 59 cents, and it's a penny up and down since then. The important take-home point is we have made a lot less progress than most Americans and most of my students think. And the large racial gaps in income markedly understate the racial gap in economic status. You see, income captures the flow of resources into the household, but it tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. And the Federal Reserve Board tells us that for every dollar of wealth that white households have, Black households have 10 pennies and Latino households have 12 pennies. And when you are low in income and low in wealth, even though all of us in the United States were in the storm of the pandemic, we were in different boats, because some boats are better able to weather the storm than others. When my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in socioeconomic status, income, and education. We now know it's more complicated, and I want to highlight the intersectionality of race and socioeconomic status. I'm illustrating that with national data for the United States, life expectancy at age 25. And at age 25, the average white person will live 5 years longer than the average Black person. That's a 5-year racial gap. But the gap within whites by education, by the way, it's similar with income, is larger, a 6.4-year gap between whites who have graduated from college and whites who have not finished high school. Similarly, within African Americans, we see a 5.3-year gap between those with the highest education and those with the lowest education. So should we abandon looking at race, given the education gaps are larger than the racial ones? And this is the intersectionality. At every level of education and income, race still matters. So white high school dropouts live 3.1 years longer than Black high school dropouts, and the gap widens as education increases. With this stunning statistic, the best of African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, than whites with some college education, than whites who have finished high school. So what do these data tell us? They tell us there's something about income and education that matters for your health, regardless of your race. But there's something else about race that matters even after you've taken income and education into account. So why does race still matter? What I want to talk about is the science that clearly indicates that racism and racial discrimination are alive, well, thriving, and pervasive in America, and adversely impacting health in powerful ways and contributing to disparities in health. When I think of racism, I think of it primarily as a societal system, just like other systems of society. And it has multiple mechanisms by which it has an impact on health. In the interest of time, I'm going to talk about one mechanism today, and that's racial residential segregation. This is a paper I published in 2001, where I argued with Dr. Chiquita Collins that it was a fundamental cause of racial disparities in health. Segregation refers to restricted residence, where you could live was linked to your race. Those policies have been deemed illegal since the 1960s, but the structures put in place still create enormous isolation and marginalization of racial populations in the United States. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and in South Africa. He showed that the framers of apartheid in South Africa in the early 20th century got the idea of apartheid by looking at how well segregation was working in the United States at that time. Importantly, Sell argues that segregation was one of the single most successful domestic policies of the 20th century in the United States. And someone says, but what does segregation have to do with anything? Well, think of segregation like a burglar at midnight. It slips into the community, awakens no one, but once it shows up, valuables disappear, like quality schools and safe playgrounds, and access to good jobs and a healthy environment, and safe housing, and access to high-quality transportation and high-quality medical care. Research in the United States indicates that all of these wonderful resources vary by your zip code, vary by your neighborhood, vary by where you live. What's the empirical evidence? William Julius Wilson and Robert Sampson, two of America's most eminent sociologists, studied the 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to those of blacks. And the worst urban context in which whites reside is considerably better than the average context of Black communities. That's the power of segregation in creating opportunity at the neighborhood level. In fact, research indicates that segregation is the central driver of the large racial ethnic differences in income and education that we see in the first place. David Cutler, an economist at Harvard University, did a national study using fancy econometric models I cannot even fully describe, but he's able to show statistically that if we could eliminate segregation in America, we would completely erase Black-white differences in income, in education, and in unemployment, and reduce racial differences in single motherhood by 2/3. All of those striking differences are driven by opportunity at the neighborhood level. And segregation and its consequences have striking exposure for risk factors for health. The first one I will mention just in passing is that access to care and the quality of care is worse in disadvantaged, segregated neighborhoods. When you are low in income and low in education and live in disadvantaged segregated neighborhoods, you're also exposed to higher levels of a broad range of stressors. I'm going to illustrate that with a study we did, probability sample of the city of Chicago, where we found that Blacks and US-born Latinos in Chicago had higher levels of major life events, one type of stressor, of financial stressors, of work stressors, of relationship stressors, of neighborhood stressors. One of the research priorities we have is to routinely capture data on geographic location of study participants. We need to link neighborhood context to our biomarker and other health outcomes, and we need to better understand how institutional mechanisms and structural mechanisms of racism, like segregation, are linked to changes in health and changes in biomarkers and risk and resilience factors over the life course. There are multiple other aspects of systemic racism that can be looked at that the research indicates, but segregation is an example of a very powerful one in the United States. So I've talked about structural mechanisms, segregation. There's also individual level discrimination. Martin Luther King indicated that discrimination was a hellhound that gnawed at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them. I developed a number of measures to capture interpersonal discrimination. One of them is the everyday discrimination scale that captures day-to-day indignities. To illustrate the power of everyday discrimination, I'm showcasing work by Professor Tene Lewis. Each line on this slide reflects a different published peer-reviewed paper linking everyday discrimination to another outcome, to inflammation, to coronary artery calcification, to cognitive impairment, to incident cardiovascular events, for example. There are also hidden ways in which stressors linked to race and racism adversely affect health. One study found that for young people looking at online traumas, someone of their racial group being beaten, arrested, or detained, or being shot by the police is linked to worse health. Another study found that over 70% of Black women in America said they are very concerned that their children might be harmed by the police. And a recent study found that of over 3,000 mothers, that mothers of children who were stopped by the police were more than twice as likely to report depression and anxiety-related sleep difficulties. A study that I did with other colleagues where we linked a database of police shootings in the United States over a 3-year window to a database from CDC with the mental health of the population in every state, showing that every police shooting of an unarmed Black person led to worse mental health for the entire Black population in the state in which it occurred for the next 3 months. And then there's stress linked to political events that can also have a negative effect on minority populations. A study done in Southern California using the Kaiser Permanente Southern California database showed that in the wake of the 2016 presidential election, hospitalization for heart attacks and strokes was 1.6 times higher 2 days after the election compared to 2 days before. So all of these consequences of all of this stress leads to accelerated aging or premature aging or biological weathering. What do we mean by weathering? Age, chronological age, captures not only how long you've lived. If you live in a bad environment, it's also capturing how long you've been exposed to bad environmental conditions and how physiologically compromised you have become as a result of those exposures. And to give you examples of the data, here's a study that used allostatic load, 10 biomarkers, and at age 55 to 64, the mean score on allostatic load is 4 for whites. African Americans reach that level 10 years earlier, a decade earlier, they reached the same level. Another study of telomere length found that at the same chronological age, Black women have accelerated biological aging of 7.5 years. And this leads to the earlier onset of blood pressure, of stroke, of cerebrovascular disease. And where do we need to go? Well, there are distinctive exposures of African Americans, and we need to understand, and other minority groups, and we need to understand how they all combine with biological profiles to affect health. We also need to understand the extent to which there might be long-term, even intergenerational epigenetic changes that may have consequences for health. We have examples of that from the literature. We also need to think of the racism in medical care that adversely affects health. We have high quality evidence documenting that. And there are questions to understand what are the drivers of these differences. And finally, we need research priorities to identify the resilience resources as well as the upstream mechanisms that play an important role. And we need interventions in the neighborhood conditions, the drivers of the inequities in the first place. I leave you with the words of Martin Luther King. True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. There are multiple upstream edifices that are producing inequities in health. Thank you.
Thank you so much, Dr. Williams.